This week on the BackTable podcast.
Putting on a headset, and I say it for anybody.
Yeah.
Get a friend's Oculus or whatever.
Right.
Put it on. You'll understand the power that three-dimensionality gives you. I think for a lot of Americans, it was the introduction using Pokemon Go or whatever, where they saw
there's a Nintendo game.
It suddenly kind of puts it into your mind of, it's one thing to hear about it. It's another thing to actually see it, that you are actually in a three-dimensional space interacting with something that's not in the real world. And just like people now are doing this in a way in a virtual space with ChatGPT, to see that you can actually interact with this kind of like knowledge base that somehow is coming up with something that feels very human. Yeah. And these things feel very real. Even though they're not real, they're virtual. They feel very real in the real space that we're listening in.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a brief message from our sponsor. Take an easier way in with the Ellipsys Vascular Access System. Learn more about their minimally invasive option for AV fistula creation, how it could benefit your patients, and important risk information at medtronic.com/ellipsis. Now, back to the episode. Hey, everybody. Welcome to BackTable. We're at SIR in Phoenix. It's 2023. And we got Stephen Hunt back on the show. Been on, 3 or 4 times now?
Yeah, thanks for having me back.
Seasoned veteran, yeah.
My name is Stephen Hunt. I'm assistant professor from University of Pennsylvania and the co-director of the Penn Image Guided Interventions Lab, the PIGI Lab at Penn.
And then a couple new guys, Gaurav Gadodia, which we met in person in Paris a couple months ago. That was a nice surprise.
Yeah, I'm Gaurav Gadodia. I was a resident under Chuck at Cleveland Clinic. That's how I got involved in this. And now I'm at VIR Chicago, prior practice in Chicago.
And is it Chuck or Charles?
Chuck's fine. Yeah.
Chuck's good. Okay.
My name's Chuck Martin. I'm one of the interventional radiology docs at the Cleveland Clinic, assistant professor.
Yeah, and we got to meet recently over the phone, and first time meeting you. Tell me about how SIR's been so far, guys.
I always find it, first of all, you get to see all the people that you've worked with over the years, and obviously meeting new people, the enthusiasm you get from all the trainees who come in and hear talks in the different sessions. My lab has a lot of talks this SIR and a lot of sessions, and to hear all the people who are excited about the new technology, the new research coming out. I've gotten a lot of my pain practice, and I know I was just on the show for that. So going to some of David Perlogo's sessions on pain has been good for me. So I don't know, it's been a great meeting so far.
Yeah, I would agree. It's been excellent to, just catch up with great friends and colleagues over the years, and then just in general, just to see just the fantastic content. It's been a great great conference so far.
Yeah, and a great showing. I mean, I haven't been since Austin, so it's been good 4 years.
It's been really impressive. I completely agree. Like how many people have been here. It's been really nice to see the meetings back. The meetings back in person.
You almost forget COVID even happened, right? I mean, it's pretty wild if you think about it.
And Phoenix is a cool city.
Phoenix is a cool city. Yeah,
that makes it even nicer.
I went to undergrad at right down the street at ASU.
Nice.
So it's my old stomping grounds, but it's been 20 years since it's unrecognizable. It's completely different from when I was here.
Oh, wow.
But anyway, so the topic today is augmented reality, a little bit of VR maybe as well. We'll see what we get into, but I got to do the simulation of MediView, which I was introduced to by Chuck, and it just really neat technology. I didn't even know you guys were working on that. I didn't know anybody was working on that. I mean, it's pretty amazing. And so I want to kind of get into that, how you guys started working on that at Cleveland Clinic, how Gaurav got involved, and also what's going on at Penn. But can you guys give, just for our audience, an overview of the augmented reality space right now? I'll start with you, Stephen.
Sure. So you really are differentiating between a couple of different technologies when we talk about this. You have virtual reality, which is essentially entirely in a virtual space. You think about a video game or something that you're in, where you're not really looking at the real world in any way, right?
Yeah.
You have augmented reality, where you're mixing a little bit of virtual with the reality. So for example, mapping an image, a holographic image over a structure, something like that. That would be an augmented reality. And then you have mixed reality, where if you think about what was the game that was out?
Pokemon Go.
Pokemon Go, where you're
That was
actually able to interact with virtual objects, but that are overlaid onto the real space. So now it's not just a matter of mapping, just simply projecting something unidirectionally, but you're actually interacting with it. And so all of those things have their own sort of benefits and ways in which you can see them interacting in IR. So if you think about something early, like in education, right? Just being able to go in and visualize the human body in 3D, manipulate that maybe with your hands, but you don't need to be looking at the room around you to do that, right? You could basically be just completely in a headset, virtually looking at a body, diving through it, learning anatomy, learning how to place a needle or trajectory of a needle. That's all the virtual space. Now you move it into actually looking at it on a patient. You can see how just overlaying the anatomy would allow you to have a better idea of the depth of a tumor, its relationship to surrounding critical structures, right? So now you're talking about, now what about if you could then manipulate those objects, like, for example, a target and place it somewhere else. Okay, I'm going to place it on this blood vessel, or I'm going to place it on this tumor, or whatever. And so really being able to mix that. So that's where these technologies all have their various benefits and limitations, and the need for developing the technology around that. And this has been done in a lot of other fields, in surgery.
Yeah.
And of course, when you think about it, there's problems related to some of the structures that we work with, like respiratory motion and cardiac motion, right? So soft tissue structures, there's also the way that they change. We think about when we lay a patient in a CT scanner in a position, it looks a little bit different than the pre-procedural CT, right?
Yeah,
so how do you do that? Conformational problems. But in certain fields, like in orthopedics or in neurosurgery, they've gotten around that because they work a lot with osseous-based structures that you can kind of map to. So that's why I think IR has been a little bit behind. And it's also just that some fields have had the commercial space move into that. And vendor-wise, those are higher-paying procedures that they can afford to have navigation systems. You think about stealth navigation systems in neurosurgery, for example.
Right.
But those are examples of that in other spaces.
Yeah. I always think about ortho when I think about VR,
Absolutely.
I mean, that's really, you look at OSO VR with Justin Broad. We've had him on the show and others. And it just seems like you're right. Like they're like years ahead of where we were, but that's all changing because what I witnessed yesterday blew my mind, but I'll let you talk a little bit on that.
No, that's awesome. I mean, Justin and the OSO VR team have done some amazing work. I mean, AR in healthcare in general. I mean, I think that orthopedics and neurosurgery are probably, just as you mentioned, they've kind of led the space for a while. Yeah, I think Stanford was doing some AR work with neurosurgery now for goodness, well over, I'd probably say comfortably, like just before the first HoloLens came out. So I'd probably say, at least 8 years, 8 years ago. And that makes sense. I mean, brain doesn't move, bone doesn't move. So just as Stephen said, when you have, data sets that you can then just kind of overlay and then, kind of provide increased accuracy, increased information. So when you're doing these fine things, you're not moving around like we're all doing when we're doing procedures. There's a tremendous benefit to that. It's just nice that we're kind of, we're catching up, and hopefully we're going to get right by them, in a short period of time here.
Yeah.
So it's interesting. I mean, for us, things just kind of started. We were just fortunate enough to have. There was actually colleagues of ours working with the headsets with a group of vascular surgeons, and that's how we actually had exposure to it, in the beginning.
Yeah. So when you saw that, like, what sparked it? Where for both of you guys, like, where you're like, I just got to get involved in this. Like, I want to, start researching this, be involved, and then we can kind of talk about, how it developed into, being part of MediView.
I mean, for me, it was just, I'm like just a big old tech geek, and I've liked the technology for forever, and it was just a matter of just figuring out how I can, kind of apply it, and it was just real fortunate that one day, as I was kind of following technology, there was in our biomedical engineering department, they were giving a grand rounds on using the technology with like the first version of HoloLens for like vascular structures. There was a company that started out of the clinic, and the researchers, or the basic science researchers, they were the ones who had actually initially kind of started presenting that work. It was super interesting, but after I finished the presentation, I just kind of went up to them, introduced myself, and explained that like I think that this really needs to have a place in IR. And for better or for worse, they didn't exactly entirely know what interventional radiology was or how to or whatever else. So we met a couple times. They had a couple phantoms. We just started kind of like kind of playing around with the tech, and they kind of came down to our department just 2 buildings over, and they kind of saw some of the work that I was doing, and that just kind of started some conversations. And then goodness, from there, it just kind of moved into us kind of formalizing things a little bit more, kind of putting together like a research project, and then that just kind of rolled, and we just kind of moved step by step after that into some real good work that actually turned into like a project and a paper, then patents, and the company,
and then developing the company.
It's been like kind of a wild process.
Yeah, and I want to get into like how you do that within an academic institution with both of you guys, because I know, Stephen, you've been involved in a number of startups, but Gaurav, how did you get involved with augmented reality and eventually MediView?
Yeah, a little bit of right place, right time. Just working with Chuck. I was a resident at Cleveland Clinic. We would always nerd out about technology things because I did engineering in undergrad, and we would just talk about different projects and different applications. And one day he said, "Hey, why don't you come over to the lab? These engineers over here are working some pretty cool things." And I ended up spending, I think I didn't go back to my rotation that day. I'm pretty sure I spent the rest of the day in the lab just kind of talking to them. And that's kind of the power of what this has. We were just talking, we just had a session on this at SIR, and it's how, and I think you said it, Stephen, it's how sticky this is. It's the page, you as a resident, as a med student, you just get engrossed in it and can see how, what the applications and the benefits are. So kind of went from there and just started working on the research side of it. And since then have kind of kept seeing how I can help anything small to big, from research to just providing some feedback to the team as it's evolved from a research team to a company.
Yeah. And from our perspective, so obviously we've had the Penn Image Guided Interventions Lab, the research lab that we have at Penn. I would say that our involvement in this was very nonlinear, but Brian Park, who's now faculty over at OHSU, was a resident with us and was very, very interested and passionate. He has an engineering background. He knows how to code. He knows how to kind of string together a lot of this. But there was a lot of interest from our part on a couple things. One is remote education. So I do a lot of global health work, right?
Right.
And so how would you best be able to teach people? And I had known about the surgical, and I know a couple of surgeon friends who do remote education using HoloLens or using Google Glass back in the Google Glass days. And so that was this, how can we do that? There was that piece of it, right? And then in terms of pre-procedural planning, we have all these animal models of disease. We have a rat model, for example, of chemoembolization. And it was like, if we could just really be able to visualize the structures better, and these are very, very tiny little MRs, right, of these rats. But if you had a better visualization, because when you position the rat, kind of where's that tumor relative to other tumors, because you're trying to do some segmental embolization. So we had a lot of ideas about this, but till Brian came along, and then his passion was around developing these tools in the AR, VR space and applying that to kind of questions that we had, we didn't really have a way of addressing them. Yeah. Then when we actually started playing with it, putting on a headset, and I say it for anybody, get a friend's Oculus or whatever,
right?
Put it on, you'll understand the power that three-dimensionality gives you. I think for a lot of Americans, it was the introduction using Pokemon Go or whatever, where they saw,
there's a Nintendo game.
It suddenly kind of puts it into your mind of, it's one thing to hear about it. It's another thing to actually see it, that you are actually in a three-dimensional space interacting with something that's not in the real world.
Right.
And just like people now are doing this in a way in a virtual space with ChatGPT, to see that you can actually interact with this kind of like knowledge base that somehow is coming up with something that feels very human. Yeah. And these things feel very real, even though they're not real, they're virtual. They feel very real in the real space that we're listening in. Yeah.
So when you're working with animals and the mice, I mean, let's talk about resolution, right? And like the evolution of this technology, because I have an Oculus, and it seems like every couple of years they update it and everything. I really want to see the headsets evolve to where they're like eyeglasses, like what you're wearing, Chuck. That'd be amazing. But just in terms of resolution with the animal models, how was it? Did it seem cumbersome? Was it like not ideal, or?
So we were using it in that particular set of experiments.
Yeah.
You're wearing it for just a few minutes before you even start the case. The point was to get an idea of the three-dimensionality of tumors, because these are multiple tumors in the liver of these rats.
Yeah.
To get an idea of, you have a target tumor that you're going to be going and embolizing, get an idea of its relation in space in a three-dimensional way versus just looking on, axial, sagittal, or coronal MR, right?
Yeah, yeah.
The same thing for when we're looking at some of our interprocedural cases where, you can, of course, do coronal, axial, and sagittal CT reconstructions. We have that, right? That's just like everybody has access to that. But fundamentally, and it's hard to quantify that, but fundamentally, you have a much better relational database in your mind when you can look at a 3D model of it. Yeah. And so this has been studied, obviously, with the printed 3D models. And now it's moving into that holographic space where, again, you can manipulate it. Yeah. And what's so cool about the holographic space, of course, is that you can then add in layers and peel them off electronically in the blink of an eye, right? Instantaneously. You can add in the muscles, you subtract the muscles, add in the bones, subtract the bones.
All with voice recognition.
You can do it with voice recognition and things like that. And so even though you're looking at little tiny structures in the rat, you could blow it up with your hands, look at those relationships to other structures in the rat. You could say, okay, look, if I'm looking at the screen now of what I'm seeing on my angiogram, if I turn the hologram a little bit this way, now I realize what I'm actually looking at from projectional space.
Right.
And I think that's where a lot of the vendors will end up, like Philips and stuff, is that you can take what you're looking at on 2D angiographic thing and automatically, and you've already have tools like that, make the 3D overlay so you're like, okay, I know exactly where I am.
Yeah, make a PTC much easier, right?
Yep.
Entirely. I mean, that's you're absolutely right.
Yeah.
I mean, that's.
I think that's what I'd struggle with this day with just that trying to visualize
spatial relationships.
Right, exactly. Yeah. But that's what kind of blew me away was that that overlay, right, over the body, and where you have your ultrasound probe and you're able to see exact, the imaging overlaying the body. So can you guys just give we kind of went through the history of AR up to today. Can you give a brief description of MediView and any other companies out there that are similar or they're doing the same thing? What are the capabilities now, and then what are we going to see in the next 2 to 5 years?
Well, yeah, I guess there's a lot there. Kind of getting back to your first point though, that three-dimensionality, that is huge. I think that's one of I think, I don't want to say the biggest selling points, but I think it's one of my biggest attractions to the technology. I mean, I know we've both have talked about this in the past, that you kind of take it for granted as radiologists. We do this in our head without even thinking. We take these complex, 3-dimensional, or working with patients, we're looking at a 2-dimensional image that's really kind of a 3-dimensional object. We kind of convert it in our head and then just kind of put needles into things.
Yeah.
And that is just automatic. And it's been like a learned process for us.
Right.
And, using AR has been really, really nice because it kind of brings that 3-dimensionality back, but it puts it right in front of you. And, truly one of my favorite things about the technology is when, we put the headset on a trainee for the first time and they just get it, especially when you have these images that are just registered to the patient. There's just this moment that it just kind of, it makes things so much easier. You just understand spatial relationships. It just, you see the smile crack across their face and you're just like, all right, they're
in a way you are moving from, right now what we do is we take the real world, we digitally encode it, and then we project it in these things that as radiologists we've learned, and as medical students we learn the anatomy, and we're able to then kind of reconstruct from 2-dimensional pictures an image in our mind, right?
Right.
You take a trainee, an undergrad or an early med student, right? You are now moving them closer to a picture that looks like reality, right?
Yeah.
And so in that sense, it's a lot less of the reconstruction that their brain has to do.
Right.
Now, you can then over time, it isn't that they aren't eventually going to learn how to do the same thing with the 2D and 3D things, but it allows for a lot more accuracy at the beginning of where they are.
Yeah.
The other thing is that we don't realize, even today, I think a lot of people take for granted, let's say you're doing a CT-guided biopsy of a liver dome tumor, right?
Yeah.
There's all the respiratory motion that's happening. The diaphragm's moving up, down. There's cardiac motion, depending if you're on the left side, right?
Yeah.
And then we're only actually taking pictures. It's not really real time. I mean, even with CT fluoro, you're stepping on it, you're moving, you're stepping on it, you're moving, whatever, right? What you actually have the capability of doing, now this is looking ahead, is that if you were actually doing it within the augmented reality space, it can be modeling respiratory motion. In fact, syncing it to the patient's breathing.
Yeah.
And as you're advancing your needle, you're not seeing what the last picture looked like. It's deforming it and saying, hey, you're,
Right.
and so there's actually a capability of overcoming barriers that we don't even realize we're overcoming. And what we do is when we get real close, we're like nudging the thing along, right?
Yeah.
The needle.
Yeah.
And then sometimes, you do that scan. It's like, got through the diaphragm, popped the guy's lung, you got a pneumothorax, those
Right.
kind of things happen all the time.
Yeah.
Because we've learned how to adapt to the fact that we're not really working with real-time information,
Yeah.
right? I mean,
Yeah.
we think we are, but it's not really. And even with ultrasound, there's a piece there where if you can have, again, knowledge or gating to the respiratory cycle, to the cardiac cycle and stuff,
Right.
you can allow for a safer procedure or a
Yeah.
more accurate procedure. And so, and in particular with ultrasound, you have the problem of sometimes conspicuity, right? Just is the tumor edge going to be as well visualized,
Yeah.
or are you seeing with ultrasound maybe the vessel's causing shadowing, and so that's or some other structure's causing shadowing,
Right.
and you're not seeing the back end of the tumor, or when you start gassing it out, in this case of an ablation, a thermal ablation,
Yeah.
now you're not able to really see what's there. And
Right.
yet, if you had a virtual picture there that was being projected, you can better have an idea in the real time. So many of the things that we count as drawbacks, many people talk about in the virtual space of, well, how are you going to account for respiratory motion? How are you going to count
Right.
those things? People are working on those problems,
Yeah.
but also we have those same problems in the real world. We just
Yeah.
don't realize that we're dealing with them.
Yeah. Do you, Gaurav, do you have anything to add to that?
Yeah, well, I was going to actually, so I kind of what your question was about, where we're at and where we're going. You asked this question earlier in the panel, and I kind of want to put it to both of you guys as two of the leaders in the space, where we are right now with the, with whether it's MetaView, whether it's things working on Penn, where do you think is the highest growth potential? Like, what is the next, where are we right now, and what's the thing you're most excited about right now, and what's kind of that next step that you think is really going to take it over the edge from a technological standpoint? Obviously there's the regulatory standpoint, all that, but we can talk about that later. But what do you think is on the horizon, or what are you most excited about?
I think that we're at the very early stages of where this technology can be used, how it's going to be applied. I mean, there are so many uses for it. I just think that what we're doing right now is scratching the surface and kind of how it's being used. I know that there are some people, certainly on the company side, that get worried when you have big companies like Apple, Google, Facebook, whatever else, kind of getting into the space. But I'm looking forward to that. I mean, more than anything else, I mean, Apple as a company, they know how to kind of normalize, really intricate technology and make it like with a really smooth user interface and
make it sexy.
Yeah, they really do. I mean, and it'll be one of those things where I think about a year and a half, I think 2024, early 2024, they'll have their like a headset out. And even as many people right now are talking about like augmented and virtual reality, I think that number is going to probably quintuple. It'll just become a little bit more like closer to like just in our lexicon.
Yeah.
So, instead of us kind of referencing like Pokemon Go or whatever else,
Right.
everybody's going to have like,
Clinical references.
There's going to be like a lot more like very, very tangible references that people will be able to use. And I think that's just going to take, the technology in a completely different way. And the other part of it is it'll also just kind of normalize it around the hospital.
Yeah.
Like, I mean, I show my patients before I use the technology. I mean, as you know, a lot of times, it's a great opportunity to just kind of bond with patients and just have like enhance a patient experience. Before I do a procedure, when I'm using the HoloLens, I'll put them in it and, just put the headset on them and, just kind of show them, all right, this is your liver. This is where the tumor is, or this is your kidney. This is where the tumor is. And, what we're going to do is we're going to take a needle and it's going to go from here. And we have to, we're getting past this artery right here and we're moving here. And, we're going to, put the needle in and then, this is what the ice ball looks like and it kills the whole tumor. And that's that. And, I consider myself pretty decent at like describing procedures to patients and getting like the appropriate level of informed consent and everything. But inevitably, as soon as you put them in that experience, the number of questions like just go up through the roof. They're like, wow, this is crazy. Like, thank you so much. And, what about, and it I think it enhances the patient engagement.
Yeah.
So I think that there's going to be things on the short term, just like we kind of talked about today in this session, whether it's education, patient engagement, things like that. I think that there are things going to be on the slightly longer term, using the technology for pre-procedural assessment, tumor tracking, navigation, ablation confirmation, whether, no matter whatever thermal modality. those are going to be, I think, probably the early wins, just because I think in this current healthcare regulatory environment, those are the easy things to do. And then I think, longer term, we'll start actually kind of being able to, kind of coupling it with, EM tracking, like we do with the work with MediView and others, and we'll just kind of progress from there. I mean, what are your?
Yeah, I mean, I think that a lot of the use cases are already out there. They're just not distributed in IR.
Yeah.
Or they're not even distributed in medicine necessarily. But if you think about, many times in the military, they use a virtual planning environment for, an air raid or whatever, and they're kind of walking through the steps. I know as an IR, I sit there when I have complicated cases. I had to do this adrenal ablation in a young kid with a pheochromocytoma. Stressing about the case for 6 months, literally up at night, thinking through approach, thinking through the imaging. It's all reconstructing my head, right?
Yeah.
But I don't have a module where I could go and enter into the virtual space,
right,
practice the procedure multiple times of different approaches, take the imaging and say, okay, if I flipped them here, how would you model the lung? Am I going to have to go through the lung? Am I have to go through the liver?
Yeah.
What other structures am I dodging? That kind of tool would be, I know immediately if I had that tool, I'd use it every single day,
sure.
right? And so that the need is there, right?
Yeah.
Or something else that, I do a lot of pain procedures now.
Yeah.
Obviously, we talked about that, but my ultrasound skills of being able to detect nerves and stuff, I'm just not doing those every day, and I haven't done it. So I take these courses, I teach myself, but you can imagine that eventually where I think we're headed is you put the ultrasound probe on, it's labeling structures. It's saying this is the vessel. Right. In fact, it's saying like you seem to be turned a little bit too sagittal or a little bit too, and so it's helping guide you as the clinician. And then, you're getting to the point where that's reinforcing your learning that you have externally of the 3D structures. And so right now what it is a lot of times we're going to PubMed, looking up a block on a 2D white piece of paper, black and white from whenever, and then going and reconstructing that as a 3D in our head, and then going and trying it. And eventually you get really good at it. Yeah, those first 10 patients don't benefit from it because you didn't quite get the target or whatever, right? And so I think that moving that to where make everybody suddenly uniformly learn the procedure with 2 tries because they're working in a virtual environment where everything is that way. Right. That's to me like where we're headed. I think that the initial pieces, we look at the other professions to see where they're using it. Obviously, like you said, the ortho and these places are using it for registration. I think the image registration piece is gradually being chipped away at. We do have some image registration software that has gotten better and is now being used for soft tissue structures like the liver.
Yeah.
So we use those grids, for example, that everyone's aware of in CT and things like that. And so you can use that, and just the lettering on that actually allows you to snap to it with certain software. So you can actually snap the 3D right onto it. And it's automatic registration. We've done some research to show that that's like, that happens in a matter of milliseconds, whereas manually trying to put an image data set onto a patient takes a lot longer, right? And I know that the company that you guys have worked with, they have their own fiducials that they allow it to then map that pre-procedural imaging to whatever's happening interprocedurally, So I think a lot of the individual pieces are there. It's just, as they say, the future is here. It's just not evenly distributed.
Yeah.
It's that notion of how are we going to assemble those pieces in IR? And I think it is going to require people being passionate about a given aspect of it. So Raul Opad up at MGH is doing a lot around education and about using this in the educational space to teach procedures, to film procedures. So you've got people working on it from that end to the interprocedural piece that you guys have worked on. And so I think it's really much more a matter of getting the entire community engaged in these tools. Yeah. And then getting the vendors, you're going to see them. It's going to be coming from both directions. The vendors doing, like we have our virtual angiography to say, okay, here's all the vessels that map to a tumor, right? The CBCT kind of stuff.
Yeah.
So we'll see it from that side, but you'll also see it from the startup side of, hey, we have a very specific problem we're trying to solve, and let's do that. And then most of those companies end up being acquired. So one of the tools that I've been using a lot is Imactus. It took me a while to get it into Penn, but I love it. I think it's for CT guided stuff. It's very, very useful because it allows you to do out of plane reconstructions on the fly while you're doing a procedure. As soon as they started getting any kind of clinical traction, they got bought by GE, right? Yeah, so it's you'll see that the big vendors, they know that these pieces of software that allow you to do your job and be more efficient and safer, that those are tools that once they get uptake, eventually. Right? I mean, all the old guys in my practice, they love, when I first got there, 2009 to Penn, a lot of them would always poo-poo the idea of using ultrasound for accessing a blood vessel, right?
Right. Yeah. Yeah.
They all use it now.
Of course.
They'll say, oh, no, I just,
Right.
But the reality is that, and all the publications even showed, yes, even for them, they have 1 in 1,000 chance of getting it wrong or whatever. But even for them, it'll eliminate the 1 in 1,000, right?
Yeah.
And for a newbie, man, it's like, 1 in 10 times you get it wrong, right?
Right.
So I think that it takes people who are not competent and brings them up to a minimum level of competence. And it takes competent people, for me, I can use that to get to a little tiny node,
Right.
20 centimeters out of plane, right?
Yeah.
And an oblique angle,
right.
and dodge a bunch of critical structures on the way and know exactly from the moment I set the probe on there, this is where I have to go into the skin, this one spot.
Yeah.
That gives me my spot, right? And that's what we hope with many of the AR/VR tools that we're able to develop it that way.
Yeah.
Yeah, I think that's the big trap of these new technologies, and you kind of really nailed it with the ultrasound example. I mean, as IRs, because I will have like my colleagues will that'll ask that even at the meeting, like I can do my procedures right now, like why do I need this? I mean, it's a fair question. It's to me, I kind of almost liken it to like a new wire, like I could probably get through a procedure without a glide wire, but God, you get the glide wire and it makes everything better.
Yeah.
There's particular wires that you use for whatever. And it just works, or a catheter. You figure things out with catheter X, but now all of a sudden you have a catheter that's shaped in the right way, and it just makes things work better. But you don't know what you have until it's
you try
right there in front of you. Exactly.
And it's not even just one case. It's like it's got to be a few cases and get your feel for it.
Yeah. And now it's I mean, to your ultrasound example, like usually toward the end of our fellowship, I'll always have like our fellows just kind of palpate and try to do it with just ultra, just a standard, kind of the old school way. And it takes them a little bit.
Oh, yeah.
It's everybody.
I do think that there are going to be skills that, for example, a lot of the old guys can do, fluoro-guided puncture, whether it be for nephrostomy or whatever. They kind of do the gun sight, line things up.
Yeah.
For those of us who grew up in ultrasound, and they're like, I don't feel comfortable with ultrasound. That's what they'll say.
Right.
Whereas for me, it's like, dude, I got a picture of my ultrasound.
Yeah.
I'm seeing myself live, guiding myself in. Why am I going to stick the central system, blow up with CO2, then stick a calyx under? It could take me forever because that skill set, right?
Yeah.
Same thing for the guys who are, World War II pilots. They didn't have any kind of system they had learned how to drop a bomb at a certain, angle and things like that. And it was a heuristic, right? It was like almost like a mind-body connection thing with the plane, right?
Pride in it. Yeah.
Whereas but they can never operate a modern jet with a kind of precision, right? The precision piece there is not, you're not going to be able to do that without these kind of tools. And so there have been cases, I call them my impossible cases. And that's what I did when I brought in navigation system like Amactus. I said, I don't want to use it for basic stuff.
Right.
I want to see whether I can do for myself cases where I'd be like, this is going to be, right? And so, something way out of plane and so what I would do is I would use CT.
Yeah.
Mark on the skin where I thought from my best guess, right, from doing 3D reconstruction, where I'm going to go in.
Yeah.
And then go ahead and just drop their little thing on, and it would be like 20 centimeters away, right? Like in the way where I thought I was going to go in, it was going to hit something or it was gonna,
Yeah.
So that's where I think that these tools, until you use them, and even Solin, who's, obviously done a lot of ablations, we had him do the same thing. Okay, show us where you're going to go in. Mark's where you're going to go in. Drop the thing on. No, you're going to end up going right through the lung to get to this dome tumor in the liver, which is a common problem. That's why we have these complications of pneumothoraces and things, because these are tough cases.
Yeah.
Right?
Yeah.
So that's where I think that's it kind of shows you how you can take a very, very adept user and kind of make him a super user,
right?
A Superman kind of thing. And then you can take a basic person, bring them up to speed. Now, they're still going to have to practice. They're still going to have to learn the anatomy. They're still going to have to learn the fundamentals, right?
Yeah.
But in some ways, it's holding their hand to teach them.
Lessons that learning curve.
Yeah.
Absolutely.
Well, it's interesting. So, and you kind of asked us earlier, Aaron, about academic centers. So obviously Cleveland Clinic and Penn, two of the biggest academic centers. And when I was at those places like Cleveland Clinic and, and fellowship and stuff, it's nice to see it's cool to do these things with the AR, but you also have, the latest and greatest Siemens or GE or whatever imaging system and image fusion and guidance and all these things, right? So now I'm in practice and I go to some community hospitals where the fluoro is literally 40 or 50 years old. They have no cone beam CT in most of these places. So when, Stephen and Chuck right now, they're talking about some of these really advanced cases, and I think that's going to be really exciting. I actually think for a lot of the community IRs and general IRs, private practice IRs, the being able to do procedures faster. There's procedures that I'm doing right now, a CT guided procedure. I have to walk out of the room every time because we don't have CT fluoro.
Right.
And it takes me forever, and it's the only CT in the hospital. So they're yelling at me like, hey, we got a stroke coming in or something like that, right? I have this headset on, I put it on, and I can get right to it. So it's interesting. I think the resources are there in those big academic centers in terms of the development, and that's where these things have come from. And I think that's really great because that's what needs to drive it ultimately until it gets taken over by industry at large or tech at large, the big companies. But I think that some of the impact that it might have on a day-to-day could be really huge. And that's what I'm really excited about in the smaller hospitals, in the places where you can really
lower resource setting.
Lower resource setting.
Exactly.
And you have the greatest tool, right? The problem with some of these things that are out there right now, image fusion softwares and things like that, is you need to have the latest system in your room. You have to build a brand new room to even use that system. Whereas I can take a headset, and I kind of said this in our session earlier, to me, the headset is kind of like the smartphone, right?
Yeah.
You can build an app onto it,
right.
And anybody can kind of iterate on it and grow it. And I think that's something that's really exciting. So the smartphone made everybody in the world have a computer.
Yeah.
Kind of the same thing is what I think the headset's going to be doing.
Well, that's the other amazing thing is like you could be in a rural setting, have it on, doing a complex case and say, call, Stephen Hunt.
Yeah.
And then he can then see what you're looking at and be like, well, actually, let's, let me help you out here.
100%.
That's pretty amazing.
Just to even say that, I mean, one of the speakers, she had done some work with Brad Wood before. She's an MD PhD student now here in Arizona, but basically using iPhone and looking at, okay, you can put the iPhone in front of the patient and have an angle of approach based on, virtual reconstruction of where the tumor is and your thing. And that, you looking at the image and placing your needle versus just holding your phone and following the dotted line with your phone, right? And it's just the phone, right?
Yeah.
Now you're talking about almost anywhere I go in the world, even the most remote places, everybody's got a smartphone now.
Yeah.
We all are walking around with a supercomputer in our pocket.
Right.
So while I think HoloLens or Magic Leap or any of these things are really, really cool, I think that developing for those platforms, and particularly now you're not talking about having to have a HoloLens in the community hospital. You're just going to pull out your phone, put it in a little baggie like you do when you go surfing, and and then be able to help it. Particularly if it's easy tools for very simple, quick guided things where you can just hold it over. Okay, this is the angle. You think about when you're doing a percutaneous cholecystectomy. You're sitting there with the ultrasound and trying to find the angle, and you spend a couple minutes doing that. Whereas if you could just flip the phone up and like that's it, boom, that's the spot. It just like and saving that 5 minutes or whatever, and having some confidence because you see the 3-dimensional structures in the space. It's hard to now. That's not giving the same degree of virtual reality, but it's the same idea of being able to do those image mapping and stuff like that. And it's about developing those tools for the low resource setting, and that's where I think it's exciting for the rest of the world because they're not going to have image fusion. They're not going to have the latest, greatest anything.
Right. Yeah, or even the glasses. I mean, they will evolve like the iPhone has.
Oh yeah,
right.
Absolutely.
And then everybody's got these Tony Stark glasses, and they can
absolutely. I mean,
do amazing things. I mean, I'm looking forward to that, and that was the whole thing. Is like when I visited the MediView booth, I got really excited because I couldn't imagine. You think about AR, you hear people talking about it, but you don't really get to experience it. Other than Pokemon Go. And that was the first time I really was like, oh, I can see using this, like he was said, in clinical applications, in private practice, improving throughput, improving, access to care for patients, stuff like that. So kudos to you guys and like all the research you're doing. And the other question I had was, any unexpected challenges? Like you guys are talking about the challenges and there's people working on those, but anything that you guys were like, wow, I didn't expect that, when developing MediView or in your lab, Stephen?
Yeah, I mean, so one piece is, how do you negotiate the transition from research to make a commercial product, right?
Yeah.
So when I was at Stanford, and I think Penn has the similar rules. It's like the inventor or of a patent will get a third, the department will get a third, and the university will get a third. And so that's a very common split for the licensing, right? But that's not a third of a company. That's a third of some patent that's going to get licensed for a company. So for example, for the Google went public at $100 billion. The patent was 1%. That's what it ended up being, equity. That equity was, a third of that 1% went to the inventors. So they each got $150 million from it. The Department of Computer Science got $300 million and the university got $300 million. That was a massive patent, right? This backnodal projection, which turned out to be a great company and whatever. But each of those guys was worth $12.5 billion that day because equity in the company, right? So it's one thing to build a company. Yeah. It's another thing to have an idea, patent it, and then get it licensed. And those are two very, very different things. You may have people who are passionate about a topic that they're willing to step out and form a company and get other co-founders and do that. That's a lot more work and you get a lot more reward, but a lot more risk.
Yeah.
Then I'm going to develop this technology and then find an industry partner who can maybe take that technology and commercialize it. And so that's kind of one of the things I think you think about. And it's ideas and working on in a research space still doesn't make for a clinical product. And you guys have negotiated that with the company that you guys have helped, develop the technology on. But there's so many other things, regulatory hurdles, expense of doing animal experiments, things don't work out exactly as you expected, or some other risk that you didn't even think about. Like, for example, you asked about image resolution. You know, how well does this represent the real space, particularly if you're talking about doing it live in a human, versus in the planning stage, it's much more about, can I get a better feel for, in the pre-procedural space, can I get a better feel for the practice the case or whatever. But when you're talking about now overlaying it onto a human, it's a different thing, right? It's another level of risk.
It needs to be precise.
So I think that's some of the challenges is just around how do you then move those things into, it's nice to build these things in academia, but they're not going to go anywhere unless you find a clinical partner an industry partner that can translate it clinically.
Yeah. I mean, we've been really fortunate in that capacity. Because as things started, like even everything with MediView, I kind of stay on the research side of it, so that way I actually can participate and serve as a principal investigator on all the trials. So it's been really nice in that the clinic was able to, or the MediView founders, they actually once we actually had some working technology like in the lab, they saw that, they believed in it, they were kind of able to pluck it away and then kind of like work with the clinic to kind of come up with a reasonable licensing strategy to then kind of actually form the company and then form it in a way that they're able to actually kind of run.
Yeah.
And then, one of my favorite, the MediView team, it's just a group of just incredible people, just incredibly smart, like technically and gifted people. But I mean, outside of that, what's really nice is that there's this really interesting partnership, that the clinic kind of fosters in a lot of their startups, but I mean, I could, certainly just speak for this one, where, as little pieces of tech get developed, literally, 2 buildings over, we're able to actually then just kind of bring it right over to the lab. We kind of try it on a Phantom, and then, it kind of iterates, and then we'll kind of bring it back. And there's this kind of back and forth that kind of happens. And then we just kind of can take it. And when we feel we have a reasonable model, we just can kind of run with it and then kind of do it kind of work with it in a patient. And that's fantastic.
Yeah.
And that, and honestly, it would be really interesting to see that, I guess, from the other side, from the industry side. I mean, because just as a clinician, that's all I know. And I feel it really kind of accelerates the process. Having said that, though, it's been a really interesting process as far as like the unexpected components, just even as far as like the research, just getting things, even off the ground. I mean, we have I think the world of we have a really robust IRB, like our institutional review board for all of our research. But even kind of getting things started when we first, this is going back years, but like kind of getting the initial research kind of through. We just kind of put together a proposal. We kind of sent it in, and there are a lot of questions that came back, and then we kind of revised it and kind of sent it in, and it kind of came back, and there was this back and forth. And then finally, which it's something that they don't do, but we had asked them to just actually kind of present in person.
Yeah.
So we rolled it in, we kind of discussed it, they saw it, and like all of a sudden there was this moment when they were just like, oh, I get it. Like,
yeah.
And it moved, and we were able to do that. For us and kind of getting to your point as far as like the unexpected components, I think that's actually going to come in now as, we're kind of going through the regulatory process.
Yeah.
Whether it's, kind of advancing our research a little bit further, or even, on the regulatory side, when you're looking at the company, like, through some preliminary conversations with the FDA, they've been great because, they understand that they know that what they don't know about this technology, but they're actually willing to work with a handful of companies to try to kind of, move things forward because they get that this is going to be a part of the healthcare space.
Yeah.
And that's, it'll be really interesting to see how this relationship and actually how the process evolves. But I think that's probably going to be the biggest source of the unexpected kind of twists and turns, I think, at least in the short term, to your point.
Is software the predominant part of it, like MediView? Is it mostly software, a little bit of hardware, or the other way around? Like, what does it fall under bucket wise? Is it device, software, imaging?
It kind of falls under the whole the med device. But it's a combination of that software, and like the secret sauce is kind of like how the software kind of interplays with the electromagnetic tracking.
Yeah.
So, and that's kind of the hardware component, like this, kind of this piece that kind of just bolts onto any table really to kind of allow you to kind of track everything that you're doing in a 3-dimensional space. And, it's that kind of interplay and the ability for anything in that space to kind of actually kind of register and kind of track in real time or near real time.
Yeah,
that's kind of the important part, and and then to do that accurately and consistently. That's
it's very similar to the ablation confirmation software we see out there, right?
Exactly.
Yeah, like Castination and those guys.
Very much so.
Yeah. Gaurav, you got anything else to add? That was my last big question.
No,
for these guys.
I think what they're saying kind of is exactly what it is. The biggest challenge is, we can do research ad nauseum, and people, this meeting is great for that. You can see all the crazy research, and some of it comes to fruition, and some of it doesn't. And it's taking that next step, especially like I said, now someone on the private practice side, community side, how do I get into my hand? And how do we get from there? And it has to come, I think, from the big institutions, because that's where the funding is and that's where the research is. And, you could ask, why do some of these companies, whether it's MetaView or any other company, why do they put up with this? In a way, not put up with it, but why do they wait for IRBs? Why do they, but I think if you ask them from the company's perspective, that's any of these companies that you're talking about. I think the reason that they approach us with these things, whether it's MetaViz or Mactus or anything, they need that input. They want the clinician input and they love it. They actually would rather spend their time working with us in these centers and talking to us about what the problems are, because ultimately, especially in medicine, why things take so long to kind of adapt, I think, is, with technology compared to other fields, is that, getting through human factors testing and IRB testing and regulatory and things like that. But I kind of want to put it to you guys. You guys talked about unexpected challenges. What is the challenge that's ultimately going to get us, or what's the next thing that's the hurdle to get us to getting into my hands? Is it regulatory? Is it technology? Is it everything? Adaption?
What's the time core? What are we talking about? Next year, 2025?
I think it's going to be a slow creep of these technologies around. It's not a linear. It's not going to be like one thing, that way. I don't think it's a linear road, and I don't think it's a linear trajectory, because you're looking at a lot of little technologies nipping at the heels, whether it be, the new image guidance technologies or ablation confirmation software or those kind of things. And so what you're going to see is that as larger vendors get in and kind of buy those up and develop those out, then some of what we do it might get superseded. Some of the stuff, ways we thought about doing it, somebody else comes up with a more efficient way of doing it. And so there's that creative destruction piece. I think that where you really got to look is, where's the clinical need? To me, the clinical need is around safety. If we can improve safety for our patients, then even if the efficiency piece is not there, people are going to buy it for the safety reasons, right? If it makes your procedure safer, right? And I would say that you think about ultrasound as a game-changing technology that way with vascular access, right?
Right. The speed comes later.
Speed also, speed might come later. Initial, it's you're trying to do this, right? It's not faster. Then I think that for people who are trying to uptake new things like bringing pain into your practice, you want something where it's like a learning module. You want learning modules that can very quickly convey that information. So I think in the med ed space, there's going to be a lot of innovation that way. And then I think that for these larger companies like Philips that bring in try to adopt a lot of those technologies to their platforms, I think that that's where we're going to see them rolling out new modules. And so that's, to me, what's immediately in front of us. On the longer term, what I want to see is that integration then with artificial intelligence, with, we know that these things are capable of doing so. Just like right now, a jet kind of says, this is where we would recommend that we shoot, and you can choose to hit yes or no,
Right.
But those kind of automatic guidance systems, that's where I think we are headed with a lot of our space. And eventually, of course, that gets married to some other physical thing like robotics. And now you have the automation that's the overall trajectory. How quickly we're going to get there, there's going to be a lot of missteps along the way, and there's going to be a lot of technical development necessary. But I think med ed's big. I think patient, as we talked about, the patient experience and bringing it in. But some IR needs to champion that, where they really feel like they want to be the person known for enhancing the patient experience and letting them involved in that process. And so hopefully the real thing is hopefully as the ecosystem grows, more people come in IR, they're going to find some piece of that puzzle that they are passionate about and try to move the ball down the field in that way.
Yeah, and that's the beauty of the meeting. I mean, you have people that'll come up to you and just kind of talk about, use cases and opportunities like that. And, there'll just be these aha moments. And and I mean, to exactly what you said, I mean, there'll be kind of fits and starts, and, somebody will get it and just who knows?
Yeah.
It'll be a work in progress.
And on that, if there's anybody listening who wants to get involved with these projects or AR in any way, how would they? What do you recommend? They just reach out to you guys?
They could just reach out to us. We're always looking. I don't want to speak for you, but that's how Steve and I got involved. It was actually at SIR, where we were just kind of seeing what everybody was doing, and we were kind of two of the few yucks that were doing,
and I think
AR
you go,
work, and it just kind of went from there.
As residents, you look in PubMed, you see who's publishing in the space.
Yeah.
And I think don't just reach out to IRs. If you have some piece of this that you're really passionate about, and psychiatry is doing, for example, a lot of biofeedback, PTSD, stuff related about trauma, and particularly in the veterans, I've seen that. And so I think that reach out to those people. They don't necessarily have to be in IR, and then think about how you could adapt that to the IR experience, or to the IR procedures.
Right.
Because that's where you have this, we don't have to reinvent the wheel. A lot of the fact that we are behind in some way in our profession, even though we own the imaging data, which is kind of bizarre, right?
Yeah.
But that allows us to take tools that are already out there and adapt them for our use. And so I'm hoping that people are encouraged that they don't necessarily have to know how to code. And if you are a coder, great. There's all kinds of problems that you can help us solve.
Yeah.
But if you're not a coder and you're more of an implementer, you want to run clinical trials or you want to do it in the preclinical space, there's all these tools. And so it's a matter of finding a mentor, whether that be in IR or not in IR. It doesn't have to be in IR. Many of the things that I've learned from thoracic surgeons. I've learned from, PM&R or pain docs, So find some mentor in that space and then take that tool and apply it as you would in some, interventional space.
Yeah.
Yeah.
And you also have, you could come to SIR, meet the people, but you can also go to the expo floor, right? That's part of what it is. You can go and meet. There's a lot of people that are hungry, a lot of industry partners out there, whether they're the big dogs or the startups that are hungry for people to adopt the technology, to try it out, to use it, even to do something on a weekend and stuff like that. So, there's a lot of things that you can do to work on that. So I think reaching out is a big thing, but we're here with the right people, right? Steve and Chuck are the guys who literally put together the first ever session on AR. That's where we're coming from now at SIR, right? An entire session on it. It was pretty full. So, so it's growing.
I think there's a lot of,
better.
I think there's a lot of passion there. And I think that if you write a grant in the space, it's not just SIR that's interested.
Oh yeah.
We hear this from the NIH and stuff. And so we are hiring one of our former postdocs. Specifically, his whole track is going to be around integrating this into our field in IR and also interfacing with the rest of the university. We had this meeting this past weekend at Penn, it's just ending, of AR, VR in healthcare. And this was not just IR, this was everybody.
Across the
and we had the CMO of Microsoft who was there sitting with our CEO, with Kim Mahoney, and saying, we are committed to making this, and they want to have Penn-Microsoft relationship just like Cleveland Clinic or just any of these other places, because they know that the technology, these are the fertile areas to work with.
Right.
But in the end, we are some tiny, tiny fraction of this big ocean, and there's plenty of room for upstarts in anywhere.
Right.
Just
like
podcasting.
You
got a smartphone. Exactly. You've got a little phone, dude. You can do this research with your phone, whether you be, Apple phone or whatever.
Yeah.
Podcasting the same way.
Yeah. I just stole from Lex Friedman. It's, they were doing really, really well. And I was like, we could do that in medicine, right? Nobody else is doing it. So, well, thank you guys so much for coming on. I appreciate it. Always good to see you guys.
Thank you.
And thanks, guys.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck, Sabine Don,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Mood. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.